Okay, so we're recording. So before we start in with sensory disorders, I want to just review what are our five main senses that we have? Sight, smell, taste, hearing, touch, yeah, feel. So today, and you're like, remember you're reading, hopefully we read. What are the two main senses that we talk about, or the chapter that talks about? Hearing, vision and hearing, right? So we're gonna spend most of our time talking about that, but let's think for a minute about some of our other senses if we have some disorders. We've talked about touch with some of our other diagnoses. If you have a disorder where you can't, like, what might be a disorder where you might not be able to feel as well if your touch is disturbed? Maybe some neuropathy. Some of our, yeah, different things involving the nervous system. Guillain-Barré, right? You might not be able to move as much. It might affect some of those things. What are some of the side effects if we're not able to feel like we should? Yeah. Potential for injury, right? We might actually be, holding our feet a little too close to the fire and getting burned, not realizing it. We talk about our diabetics maybe getting bruises or blisters on their feet, causing wounds that they don't know about. What about, I think about taste and smell being very closely related. A lot of our patients after COVID, my dad included, once he had COVID, he's recovered from it, but he never recovered his sense of smell. So my dad still can't smell anything, and his sense of taste is affected by that. How does that impact our patients? Malnutrition. Right, they maybe don't want to eat, maybe some malnutrition. Over salty. This is exactly, I was hoping somebody would say that. My dad has hypertension, he has a lot of heart problems, and he dumps salt on his food. I'm like, Dad, you can't even taste it. And he's like, yeah, but maybe if I add enough salt. I'm like, Dad, but we try to do the nurse education and also be a respectful daughter. So just know that all of our different senses, if we have a disorder of any of them, it can cause complications. And so even though we're focusing on vision and hearing, those are kind of the main ones we see. I don't want us to forget about a loss of some of our other senses as well. Okay, hopefully you're all in the Menti. Well, let me click back in here. Okay, so we're gonna go through and talk about some things you've probably heard about, dealt with already, but maybe you haven't, or you're not super familiar with these names. So has anybody ever felt their eyes being really dry? Yeah, most of us have. And if it becomes a chronic condition, maybe not like occasional dry, but chronically dry eye, it's called keratoconjunctivitis sicca. What a big word. Usually they say dry eye disease, unless you have an ophthalmologist that's writing the note or somebody who's like specializes in it. What are some things we can do to help patients that have dry eye disease? Eye drops, right? Anybody in clinicals had patients that have to have the lubricating eye drops? Yeah, right? And what are those, when you guys look at those eye drops, especially the lubricating eye drops for dry eye, what is the texture consistency of those drops? You guys notice that? Yeah, a lot of times they're pretty thick compared to our medicated eye drops that might be doing something like reducing pressure or something else in the eye. These drops are very thick because kind of like if your skin's really dry, a lot of times you want to put like a thick moisturizer on. That's kind of the similar thought that with really dry eyes, we have this kind of thick moisturizer we're putting in the eye. Okay, the nurse is caring for a patient who has bacterial conjunctivitis. The patient would require further teaching if stated which of the following. So before we answer, let's just read the question, make sure we understand. What are some of the key words or phrases we're going to pull from here? Bacterial conjunctivitis. Further teaching. Yeah. What does that further teaching tell us? Right. Then what does a patient not understand? So we're looking for false statements. So go ahead, and this is a select all that apply. Well, I like when we have variability in our answers. It's always nice. Okay, so looking for false statements, we did pretty good. So when they say it's not a contagious infection, well, we know it is a contagious infection, right? And antiviral drops are used to treat it. What's wrong about that statement? Antibacterial, right? Because we're looking at a bacterial conjunctivitis. It is called pink eye. That's kind of the common term. It causes, and where's your conjunctiva at? Right? Yeah, it's like the white part of your eye, right? It's like all like, or not the white, excuse me, the red part of your eye. It's like you pull down, you can see all the blood vessels, and it's a mucous membrane. It's nice and moist. So it will cause redness, itching, pain sometimes. And why is frequent hand hygiene essential? It's contagious. We don't want to spread it. Telling you guys, hand washing. It's so essential to almost everything our patients are going to experience. So I pulled a lot of really fun pictures from the internet. But this one is somebody, maybe an older adult who has conjunctivitis. You can see there's more of redness of the sclera more in this. You can't see the inside. But look at this one of the kiddo over here. What do you really know about the kiddo? The goopy, the exudate might be another word for that. A lot of times with pink eye or bacterial conjunctivitis, there's a lot of like goopy exudate. In fact, sometimes our patients will say if they have it, they wake up and their eye is kind of matted closed with this, especially with little ones. This can be hard because little ones, what might make them more at risk for getting bacterial conjunctivitis?
Because they're always dirty.
They're always dirty, right? You're the little ones, they're always touching everything. They're always touching themselves. They're exploring, they're figuring out the world, makes them a bigger risk for picking up things like this. So little ones wake up in the morning and they're all matted closed. So really getting a nice warm, moist washcloth and holding it there and wiping it away can help to get rid of some of those goopy oopies. All right. I'm going to struggle with these words today, guys, just letting you know. Blepharitis. That's where you have inflammation of the eyelid margins. If you look at this picture, and the reason why I pulled pictures is because I love to see when I'm learning about something, I want to see it. And your book didn't really have very many pictures about some of these eye conditions. This, to me, it kind of looks like somebody put kind of a pink eyeliner right along the eye line, like around. So that's going to be what it looks like in your patients. It's a little bit irritated. It might be a little bit raised or swollen with your patients who have this. What might be some indications or interventions we could do for these patients? Cold compress, maybe a warm compress too, just more of like trying to release some of that inflammation. If it is infected, it might require some eye ointment or things like that to treat the infection. Okay, this one is called a cordolum. I feel like that sounds like something from Harry Potter, right? But it's also, is it called a sty? Yeah, this one is the one that's called a sty. And so I took these two different pictures because you can see it can occur both in the upper part or upper lid or in the lower lid. Anybody ever had a sty before? Yeah, they're kind of painful, they're irritating, they're more self-limiting. It's usually, so staphylococcal abscess, where do we have staph? It was everywhere. It's part of our normal flora. So it gets kind of into one of these glands and it causes a little infection. What can we do to help treat a sty? Antibiotics, if it's severe enough. If it's not, a lot of times just symptomatic, you can do warm compresses, try to help increase blood flow, kind of to clear that the backup in there, because it's in that sebaceous gland, right? And our sebaceous glands excretes like oil and things. So a lot of times if it gets clogged up in there, so if we can increase the blood flow, sometimes we can help get things flowing through there. Excuse me. So I'm so sorry, guys. I literally feel like I have a frog in my throat. Okay, so with the hordeolum, they're kind of on the edges of the eye, the sebaceous cysts. The chalazion, I'm sorry, I should have practiced saying these more. These are more in the underside of the lids. So you can see there's one at the top. That one's huge, which is kind of strange looking, but it really shows how if it gets really large, it's not really on the outside, it's on the underside of the lid, but you can see it kind of not popping through, but it's, it's making a distortion in that lid because of how it's growing. Same thing in the under eye. These ones usually require a little bit more intervention by our medical team, sometimes having to go in and manage them or have antibiotics, things like that. They're more, and these ones are usually a lot more uncomfortable than like a sty. Why do you think that would be? Yeah, right. Like it's really pushing, like you can see is this one's really big, but they're really pushing down. The other ones, they're more external, right? The pressure's going outside, really, like it's kind of growing out. With these ones, it's going, the pressure is kind of headed in towards the eye. So you can actually have like where you can irritate the cornea and irritate parts of the eye because the pressure of these are pushing inward towards the eye. All right, keratitis. And that picture I had earlier with the pink eye, that with the older man, that was probably had more keratitis. We couldn't see the pink eye as well. But that's inflammation of the cornea. Something happens to irritate the cornea. It could be something like the chalazion or something else that happens, and the cornea gets really red. Usually you see a little bit of the sclera getting red as well, that white part of the eye. It causes usually really a lot of pain and impaired vision, right? Because when we have the cornea, that piece of the eye that gets all irritated, we're not going to be able to see as well, and it's really painful. Okay, so we talked about different infections, inflammation pieces of the eye. Now we're going to talk about vision issues and vision disturbances. Now, some of you guys, I can see, have some visual disturbances. How do I know that? You're wearing glasses, right? Sometimes you can't see, like I'm wearing contacts. If I wasn't wearing contacts right now, I would not be able to see Tara's face. I am very, very, I'd say blind. It's not truly blind, but they do put it on my driver's license that I have to wear glasses or contacts to drive because I just cannot see well. I remember when I was a small kid in school, I would tell my mom, I can't see the board. Like, and they would move me up to the very front row and I'd be like, I still can't see the board. And so I remember being so excited when I got glasses because I could actually see things. I remember being like, whoa, that tree, and I could see a bird in that tree. Like it was pretty amazing. It was pretty incredible. So we talk about vision and the types of vision impairment in a couple words. So emertropia is normal vision. I'm not going to give you emertropia or anything. I'll talk about somebody with normal vision. But you're going to need to know astigmatism and presbyopia. So astigmatism is when you have unequal curvatures in the cornea. Why is that important to people? Well, if they have to have any kind of eye appliance or contacts, things like that, they actually have to be shaped a little bit different for these people. And with presbyopia, they're going to have loss of that lens elasticity. We'll get more to that in a minute. So a lot of you guys who maybe have glasses or some vision loss will understand this hyperopia and myopia. So I think, do I have the picture in here? Yeah. So this is, I put in a lot of the little picture resources from all these little pictures are in the weekly resources page. So myopia is that you can see your things. Like you have myopia, I can see my thing in front of me. I can see real close. If you have hyperopia, I can say hi to all of you guys in the back because I can see you all in the back. So that's how you, it kind of could help you remember how to think about that. Sometimes the pictures of looking at the vision and how it changes. Like here's the hyperopia, what happens, and then here's how you can correct it. Oh, I don't think yeah, we're gonna do that. Sorry. Sometimes I talk to myself. So blindness. Blindness is where you have something happens, there's obstacles to the rays of light coming into your eye. Or it could also be where your nerves, right? Your eyes function just like everything else, where they're innervated. And if something happens to damage those nerves, you might have the sun coming through, you might have light coming through, but because of the nerve damage, you can't see. So you could have blindness for a couple different reasons. That kind of makes sense. Something's either blocking or something's actually damaged the nerves there. So visual field abnormalities, I just drew little pictures on here or drew lines because I couldn't find a way to cut up this picture. But this kind of, we'll go through each one of these overall. But look at this picture up here, these two little sweet boys holding their balls. This is what normal vision should look like. We're going to go through each of these. So diabetic retinopathy, that's going to be the most common type of retinopathy. This is what kind of happens. You have these microaneurysms in the eye, and it's like leaking, right? An aneurysm is like an opening up of the vessel that's leaking blood in there. And so these areas of the eye, like where it's leaking, it kind of lose spotty parts of their vision. What do they do? Well, we really try to prevent it, right? We didn't talk about that so much right in the slide, but we're trying to teach, especially diabetic patients, let's keep our glucose under control. Hopefully we can prevent retinopathy. If we can't, if they already have retinopathy, they can go in with a laser and try to shrink some of those blood vessels. Or if they have a bunch of fluid that's in there, that's what's causing, like they've had aneurysms that have bled into there, they can go in and pull some of that blood out, and that might help to correct some of the vision. You can also eventually have retinal detachment that happens as well. And that's where the retina totally separates. If you have retinal detachment, it's going to be something very sudden and a very acute change in your patient. Maybe you work in a clinic and they're going to call and say, I can't see, or my vision is suddenly incredibly worse from what it was before. And so that's it's an emergency situation. We want to look through right away. Sometimes they say they're looking through a veil. Like all of a sudden, it's like, wait a second, like some gauze has been down and I can't see like I normally would. And sorry, I think I said pain. It's no pain with retinal detachment. It doesn't hurt. It's just that sudden change in vision. So like I said, it's emergency treatment. Sometimes they'll go in with the laser surgery and try to reattach. Sometimes my dad had this pneumatic surgery. He was having some retinopathy, and they go in and they put air bubbles in, and they try to anchor everything back in place. And then you have to hold your eye at a certain level and do all these things. And it was interesting. I was like, that's so strange. Or they try to buckle the sclera, where it's kind of like your sclera, the white part. They try to almost make where it kind of bends in a little bit and kind of reattaches that retina. So there's a bunch of different types of surgery that they can do, but for some people, depending on if it's caught right away or not, it might not be able to treat them. So that's why we want to teach, especially our patients, if they have retinopathy already, they already have issues with their retina. What kind of things do we want to teach them to look for? Yeah, sudden vision change. Anything that suddenly happens, even with no pain, because pain is usually what brings people in to see medical help, right? Usually they're like, something hurts, I know it's wrong. But we also want to say, hey, even if it doesn't hurt, we want you to get some help. We want to make sure you're checking this out. All right, glaucoma, changing to another type of eye disease. So here we have our two little boys with the balls, but you can't even really see the balls because you have this narrowed window that you're able to see with glaucoma. It's so, and just so we talk, glaucoma is kind of a group of diseases, but generally overall, when we talk about glaucoma, it's where you have increased pressure in your eye. Hopefully a lot of you guys are getting your eye checks done, like routine eye, like kind of routine physicals for your eyes. Do you guys know what the test is that they test for glaucoma? Yeah, what does it feel like?
It's like a little flutter, like a little feather kind of sort of, it puts on your eyeball.
It does like a puff of air.
Yeah,
Yeah.
okay.
Yeah. I hate, anybody had that done? I hate it so much. It scares me every time I jump back and then I have to get back up to do the other eye too. But what that does is by putting pressure on the eye, that air puff, it actually is able to read how much resistance your eye is giving. And it tells that machine how high your pressure is in your eye. Um, so that's how they test for increased eye, or one of the ways that they can do general screenings for increased eye pressure, which really what they're looking for is glaucoma, because that's where you have that increased pressure in your eyes. So with that increased pressure, it usually doesn't cause pain, but it will cause this progressive worsening of vision. And it's not reversible. There's not really a lot we can do to change it, which is why we have that as a general screening. Even like our kids will get this eye puff test so that they can see if there's increased pressure, because once that vision is lost from glaucoma, we don't have a way of correcting it. Um, it can lead to blindness. And if they have glaucoma, we need to do lifelong treatment for it. What are some of the treatments that we have for glaucoma? Eye drops. What do those eye drops do? They lower the pressure. Yeah. Would you guys know some of the names of those medications? It's usually the ones that have Prost in the name. Something Prost. Do you guys know what some of the fun side effects we have from those medications? Oh, those aren't fun though. What they discovered in our patients with glaucoma who would get lantoprost or some of the other Prost medications, you put it in your eye. Some of it gets on your lashes, and it actually causes your eyelashes to grow. So if you've heard of the meds, like they have Latisse or some of those other medications, or they like, you know, you can get medications, you can buy them other places and you put them on your eyelashes to make them grow longer. That's the same medication they get for glaucoma. It's just one of the side. You don't actually do the drop in your eye to make you have long lashes. Usually they tell people to paint it along their lashes. So anyway, just kind of like Viagra was a heart medication, right? It was for blood pressure initially, and then they realized, oh, there's some other effects that it has. So anyway, it's always interesting to me how we have these other effects. So if you have somebody who has glaucoma and they're on one of the Prost medications, look at their eyelashes. If they've been on it for a while, usually they have pretty like lovely eyelashes. Okay, so with a couple different types of glaucoma, there's two main types we're going to talk about because remember it's a group. Primary open angle glaucoma, that's where you have like the system, you have this fluid in your eye, right? And just like any type of fluid system, like we have our cardiovascular system that has fluid that moves freely, sometimes it can get blocked. And if that fluid gets kind of blocked in the eye, it's going to build up pressure. With POAG or POG, I don't know. Have you guys ever heard of like how to say this POA? Oh, we'll say POG. That'll be fun. Usually the pressure is greater than 20 millimeters of mercury. Um, Prevalence, I thought this was really interesting, 4 to 5 times greater in African American people than in our Caucasian population. So really important, if we have people of color, we want to make sure we're looking at their eyes especially. So signs and symptoms, you might have a little bit of aching in the eye, but generally it's not painful. Headache, visual changes, and sometimes halos around light as well. That's a primary open angle. This is one of the little things from your book, the 3 Ps of open angle glaucoma. It's preventable, it's painless, and it's permanent. So then the other type of glaucoma we're going to talk about is angle closure glaucoma, ACG. And so that's where the narrowed angle, the angle itself is what causes the fluid to get kind of trapped in the eye. It's a medical emergency because those pressures are going to be over 50, right? How much were the pressures on the the POG? Yeah, 20 or more. So if you have somebody who's hitting pressures at 50 or more, man, you probably have somebody who has angle closure glaucoma. Highest prevalence is in our Asian community. So if we have somebody who's coming in and they say they have severe eye pain, right? Because this is usually painful, severe eye pain, blurred vision, also halos around the lights. We're thinking they might have angle closure glaucoma. So the two big things, like so for comparing and contrasting, what are some similarities between these two? Halos, vision loss, right? They're gonna have increased pressure. What are some of the differences? Pain and no pain, right? Also our populations who are gonna be more at risk, right? All right, so we talked about miotics, which are going to be medicines to shrink the pupil. And then we might also give them medicines to decrease the production of the aqueous fluid. Decrease that fluid in the eye, you're going to decrease the overall pressure. So some of the contraindications, we don't want to give them mydratics, right? So miotics shrink the pupil down. Mydratics are going to open up the pupil. If your pupil is widening, that's going to increase the pressure in your eye. It's going to make glaucoma worse. It might send them into some vision loss. So examples of myotics or mydratics, atropine, diphenhydramine, or Vistaril. Those are all things that are considered mydratics, and they're going to dilate your pupil. So if we're dilating the pupil, we're causing increased pressure, we know that it's not reversible if we start causing damage. So we really want to avoid these. It can cause blindness. So let's talk real quick activity cue. If we're taking care of an 80-year-old female patient and she was reporting some difficulty sleeping, her healthcare provider ordered diphenhydramine, 25 milligrams PO/PRN for sleep. She has a history of hypertension and ACG or angle closure glaucoma. What do we do? Turn to your partners real quick, 10 seconds. What do we do with this? All right, let's compare your answers to F.A. Davis. It says, hey, don't give the medicine and notify the healthcare provider. Like I've talked about before, this is, did we say we're at a resident? So when they say resident, a lot of times I'm thinking like long-term care, right? And so there's a lot of patients there. And I talked about before, our different providers, they might be covering for multiple long-term care facilities. A lot of times they can't remember what everybody's past medical history is. So it's our place as the nurse to be an advocate for those patients and say, hold on, I hear you, but I heard somebody say concern, right? I have a concern. I am concerned. I'm uncomfortable giving this, right? Cuss them out. So myotic means little pupil, and mydratic means big pupil. So this is nice little visual. We talked about that. Okay, so for glaucoma, it's not like once blindness or once the damage has occurred, we can't reverse the damage, but sometimes we can go in and kind of help it from progressing or help the pressures from increasing more. Sometimes they can go in and do some surgeries where they try to put in shunts, reduce the pressure. They might pull some of the fluid out. All I want you to know is that all of these are aimed at reducing the pressure in the eye. You don't have to know what all of these different surgeries are. Just know if they're going to have a surgery, it's all reduced at decreasing that pressure in the eye. Because what's going to happen eventually if that pressure continues on?
Fragile vision loss of irreversible.
Yeah, irreversible vision loss with these guys. All right, so the patient's caring, excuse me, the nurse is caring for a patient with cataracts. During data collection, which finding would the nurse expect? Select all that apply. Okay, good job, you guys. Mostly right. So loss of visual acuity, halos around light. They're going to be have sensitivity to the glare, and then decreased color vision. But with cataracts, we're not going to see pain, usually not painful. So with cataracts, again, we've got our little picture of these sweet little boys, but unlike glaucoma, where it was like just we could only see the center, now the whole thing is kind of blurry. So one of the things they really struggle with cataracts is night vision as well, because if you're already kind of blurry and then you're taking away light from it, it can be very difficult to kind of see the differences, especially with the color distortion as well. It's tough to have that depth perception and be in visual acuity. They also have sensitivity to glare, and we're going to see increased incidences of nearsightedness with these guys too. So sometimes they can do an implant, they can kind of do a removal of the lens, things like that to help with it. Here's a nice little picture. So the cataract, it makes the lens kind of cloudy. So that's kind of what you're seeing right there. It's like they're looking through a cloud. It's like similar to like looking through the veil, like we talked about earlier. But the treatment is where you remove that cloud, remove that lens, and maybe put a different lens implant in. All of these eye surgeries, I'm in such awe of patients who have eye surgery because for the most part, a lot of them, you're still awake. You might be given some sort of sedative and then they numb the eye to keep it still. And then they're,
That part
Rings.
hurts.
so yeah, you've had it. Yeah. I mean, I can't imagine just sitting there and like having surgery on your eye while you're awake. That sounds like a horror movie. But anyway, it's amazing. It's amazing the things we can do. All right, macular degeneration. Okay, so this is kind of, I think of almost the opposite of glaucoma in what patients can see, right? Because glaucoma, they had that narrowed, they could only see kind of the middle. Macular degeneration, it's like opposite. It's like the middle part is all of a sudden taken out. They can't see from like this middle area. So there's two different types. There's wet and dry. You're going to mostly see patients with this dry macular degeneration. 70 to 90% of patients, that's what they have. It's really common in over 64 years old. In fact, once you get over 65, it is the leading cause of vision loss for patients, regardless of ethnicity. It's just the biggest cause of vision loss. So it's progressively, you're losing they call it the central near vision. So that central piece. Oh, I don't want to get into the pictures. Here is the,
What did you say the opposite of macular?
oh, glaucoma. And it's not opposite in what it is, it's just opposite in what they can see. Yeah, because in glaucoma, you just see the middle. The edges are dark. In macular degeneration, you lose the middle. You can see around, but you can't really see the middle. The Amsler grid, we'll have people look at this because we say, look at this dot. And then with people with macular degeneration, there's this distortion of what they see. So that's a way that we can teach patients to screen for it, even themselves. You might see it maybe at some like senior living place or activity center where they might have an MedSurg right around to say, hey, take a look at this. What does it look like to you? Because if it doesn't look like straight lines, you might need to get screened more. So interventions, if it's dry, there's not a lot we can do for it. And remember, dry is going to be 70 to 90% of the cases. So kind of unfortunate if that's what you have. It's kind of this progressive loss. We don't have a lot of things to do. But if it's wet, there are some medicines that can kind of, I think of them as like drying up the eye essentially, that can help with that. Okay. Eye trauma. We put it in here more because it's a reason why people could have vision loss, right? It's not something like all of these other issues we talked about. It's where there's disease or pathology of some of the eye structures themselves. Just like similarly, we talked about like kidney disease, right? You can have maybe the nephrons that are having dysfunction, right? And that is where you have kidney failure because of that. You can also have kidney failure because you might have blunt trauma to your flank, and that might damage the nephrons. They're different reasons why, but it's still going to have the same effect, if that makes sense. So you might have damage to your lens of your eye or other things that occurs because of a pathology, or you might have a penetrating wound or something that, hits your eye. My husband, he tells a story about he and his brother were playing with sticks and we're fighting with sticks. And then my husband poked my brother-in-law in the eye with a stick, and he's had to have glasses ever since because he caused damage to his eye, and it causes problems. So the main reason we see eye trauma are so foreign bodies, you get something in your eye, burns, abrasions, lacerations, or penetrating wounds. Any of those things can cause permanent damage to the eye. So anytime you guys, once you graduate, and maybe even now, you're going to get people that are going to go, oh, you're a nurse. I have this question for you. Anytime with eyes, especially because our vision is so precious and there's so much to it. I'm always like, something with your eye, go, call your doctor. You need to go. I don't feel comfortable telling you what to do. You need to go get that checked out because we really don't know what's going on. And I don't have the equipment at home to really look into it, like look at the eye. And I'm not really trained for that anyway. So anyway, send people off, tell them to go see their healthcare providers. One thing I do want you guys to know, if you have a foreign object or a chemical, a lot of times they're going to have some saline irrigations. I put these pictures in. I had a hard time finding a really good one of the Morgan lens. Have you guys seen the top picture of the eye, like with the water coming up? You'll see this a lot in a lot of like facilities and places like that. That's where if you get like body fluids in your eye, or you get something chemical splashed in your eye, they might say first go right away, go one of these, you hold your eyes open. Anybody had to do one of these ever? Yeah,
Yeah.
it's pretty horrible, isn't it?
Mhm.
Yeah, you feel like you're getting waterboarded. Like, it's horrible. Over time though, like let's say, so this bottom one, this is somebody who probably got some chemicals in their eye somehow, or something happened where there needs to be longer flushing, like so 15 to 20-minute irrigations directly in the eye. So they have these things called Morgan lens, and that's what in this black picture, I had a hard time getting a really good picture, but essentially it's a very soft plastic of some sort, silicone maybe, lens, like a contact lens, but a little bigger. It has a hole in it that's connected to a little tube or catheter. What you do is you put those in their eyes, and you hang them up. Usually they have like saline or some sort of irrigation on there, and it just flows. It flows through and gives continual flushing. A lot of times if people have this irritation, burns, these actually feel very good to them. It can be very relieving of a lot of the pain and discomfort they're having to start getting that flushed out. So it looks really uncomfortable. It can actually help them feel better, and it helps treat the condition. So if you end up working in ER or urgent care, you might even get to put these in sometime. Let me know if you do. Like send me a message. I'm curious. So eye trauma. Enucleation is when you have the entire eyeball that gets removed. And so sometimes if there is enough trauma, they might have to take out the eyeball. Super important you're doing your assessments. Look at that. Like I've had one lady I had years ago, and I remember I was checking for Perla, and I'm like, this pupil's not moving. And then she goes, you noticed my fake eye, didn't you? And I was like, yeah, I did. And it was really cool because her original eye, the one that was real, was a really interesting color. Like it was green and brown and it was beautiful. And whoever had designed and made the fake eye did a great job of making it look very, very real. And they really did the same green and blue. It looked so pretty. Like it looked very similar, but like the pupil won't move, right? Because it's not actually real. Anyway, so needless, like whoever had done the assessment before me had not found that and did not pass that information on to me. So that's why I was like, oh yeah, I didn't know you had a fake eye. So important to note those things, but then also pass them, like document and pass those on so we know what to look for or not to get all surprised at like, oh my goodness, like your eye is not real. Uh, sorry, folks.
Perfect.
Yes.
I just want to share with that.
Yes.
Clinical,
Yes.
I had a patient that they did an assessment, but they didn't put it that she's blind on the right side. So I was standing and so she moved her hand and I thought she just purposely smacked me in the face or something.
Oh.
And she was like, oh, I'm so sorry. I'm completely blind in my right eye. I was like, but it was that way.
Cause you don't, yeah, cause if you don't get it passed on to you, you don't know. And that's so important, right? Like we want to stand on the side they can see, or we want to talk to them at the ear where they can hear from if there's partial blindness. Yeah, that's a really good point. Okay. I want you guys to take note of this chart, and in your little mini groups, you're going to try to determine which eye disorder it's talking about. So come here, see if we can all see it. So there's 4 different eye disorders on this chart, and you guys are going to be detectives and figure out which disorders at the top. So for the first one, it's got the primary symptoms, vision loss here, and then therapeutic measures. So go ahead as a group or in your little groups or join a group, see if you can be detectives and determine which are the 4 of the eye disorders that we've talked about. All right, let's check your answers. All right, so the first one, primary open angle glaucoma. Anybody get that one?
Yeah.
See some nods. Second one, macular degeneration. Yeah. Third, diabetic retinopathy. Ah, yes, probably because of the central vision acuity. What could have been your clue that you knew that it was diabetic retinopathy? The microaneurysms, right? Because we know that it can be from those microaneurysms that happen that flood the eye with blood. And so that would be a clue there that laser surgery to stop the aneurysms. And then what about cataracts? Did people get that one? Yeah, okay. This would probably be a good table to use when you study for the test, right? Or maybe creating tables like this to help you study for the test. All right, so the nurse is caring for a patient who has presbycuous. Which action should the nurse take to communicate with the patient? Oh, what is anybody want to remember what presbycuous is? Hearing loss. Yeah.
It does sound like a spell.
So somebody has hearing loss. What should we do to communicate with the patient? I like that we have some variability here. This is good. All right, so we want to face the patient. Why do we do that if somebody has hearing loss? See your lips, right? Even if you don't read lips, if I cover up my mouth and you're trying to hear me, it's a lot more difficult to understand what I'm saying. Partially because we all read lips naturally a little bit. Stand in front of a bright background light. That's incorrect. Kind of exactly opposite of like facing, because we want the back. If you have a bright light behind you, you can't see the person as well. So that's why it's about the vision and not being able to see your face and your lips. Stand on the patient's reduced hearing side. Well, it's, what's wrong about that statement? Right, you want to stand on their good hearing side, right? We want to stand, I have a old college friend who she was really hard to wake up because she was deaf in one ear. And so she'd always sleep on her good ear because then she couldn't hear anything. And so we'd be like shouting at her and then we'd be like, have to like wake her up, shaking her. She'd be like, oh, it's on my good ear. And she couldn't, like, she'd have a hard time hearing things. So you want to make sure you got their good ear. Speak softly and over articulate words. What's wrong about that statement? Yeah, and I don't know if the over articulate, because sometimes, especially if somebody's reading lips, we might want to say our words very carefully and articulate them, but we don't want to speak soft because they might have a hard time hearing us. So we don't speak softly when we have hearing loss patients. We do use lower tones. What type of, like, that's those higher pitch frequencies. That's what we lose first. So the higher up you speak or the higher your register is, the more difficult they are going to have to hear you. If you can, sometimes with my patients with hearing loss, I'll make my voice even deeper to try to help them understand, but they can actually hear those tones a little bit better, those deeper tones, and use appropriate nonverbal gestures. Yeah, I mean, right? We want to try to explain, like, here, your remote, the TV, you know, like you can use those types of things, but if you don't know sign language and they don't know sign language, you probably don't want to try sign language. Okay, one thing before we go on break. I think, do I have it? Okay, can I go here? Oh, I can go here, okay. All right, so if we could, let me turn the sound up make sure it's at a right volume. All right, so let's try to minimize background noise. And I want you guys all to pay attention. This is a group test and it's gonna slowly increase, go from like a low pitch to a higher pitch. And I want you guys just to make note of where you lose that sound, where you cannot hear it anymore. Because there's gonna be some people that can hear it longer. Some people who lose that hearing, like don't hear it. Anyway, it'll make sense. All right, we ready? Anybody still, did anybody hear it to the end? What age was it that you guys, like, did it say your age that you lost it? 25?
45.
35, 55, right? So I like these because if you're not in a group, sometimes you're like, well, that test is rigged. Of course it ends there, that sound ends there, but it's kind of interesting to see that there is hearing loss that happens over time. It's natural. We're all gonna lose some hearing, and it's those higher pitches that we lose sooner. So some of our people who are a little bit younger probably were able to hear more of those higher pitch sounds. And some of us who are a little bit older had difficulty, couldn't quite hear all the same. So anyway, we're going to end, we'll take a break right now since it's kind of a fun place to end. Let's take about 15 minutes. So come back at 9:15. Just so you guys know, we're probably going to be done a bit early today so that we can start taking the ATI test. It's a long one. I need to look up I want to say it's 150 questions.
We start now.
It's right, but that's, guys, that's why I keep doing longer and longer tests, because how long is the NCLEX? Minimum of 85, maximum 200, I think, am I saying 250? Somewhere in there, right? And so I want you guys to have that endurance to be able to test, because you're all gonna be great. If it was a 50-question test, you would have that test endurance. You might not have the test endurance to take those longer tests. So we're gonna get it, we're gonna build it for you. We're gonna get there. Okay, let's come back at 9:15. All right, let's talk about hearing. So, this is just some of the therapeutic measures. So you guys have all seen patients with hearing aids, right? And there's also cochlear implants as well that can actually send like signals that the brain will interpret as sound to help them to hear. Here's the like you guys have seen, like it goes through the thing about a hearing aid helping them to hear. A lot of times there's a volume control on it. A lot of the newer hearing aids are really interesting because they can pair to smartphones or other devices. And so some I've seen people who like they play music through their hearing aids through their phone, and there's some interesting communication tools. They are ways they're incorporating that. Cochlear implants, this is where you have something, so this is kind of underneath the brain or underneath the skin. You have this receiver stimulator, and then they wear this external piece, and it takes up what you're hearing or what we would be hearing, and then it sends it as a signal that the brain then interprets as sound. So, little activity cue. Let's say you're taking care of Mr. Olson, and he's an 84-year-old male resident of a skilled nursing facility. He has a hearing aid, but he doesn't use it. Sounds really familiar. Get it? Sounds familiar. He reported, it makes a buzzing noise. I can't hear anything. What do you do? Yeah, so turn to your people, talk about like, what do we do about this?
Typically you check. I have a patient. Years ago, very like.
All right, let's compare your answers to F.A. Davis. And they said, hey, let's look at the hearing aid over a soft surface. Why a soft surface? Yes, we don't want to break it. Same thing for dentures. If you're ever cleaning dentures, hearing aids, any of these very expensive, very personalized items, put like a towel or something underneath, because if you break them, oh, it's just a nightmare. Paperwork, lots and lots of paperwork and stuff to do. Okay, we want to look for any earwax, might get kind of impacted on some of those areas. Make sure the door is closed completely. Sometimes that door of the battery isn't closed completely. That can make a buzzing noise that the patients can get really disturbed by. Make sure he has the volume on low, and then have him gradually turn it up so he can start to hear it. And then if it doesn't help, you might need to check and see, make sure there's not something else going on. I heard somebody say, look inside of his ear as well. Not a bad idea, right? There's some crazy things that we can find inside people's ears. You know, especially if somebody's got a little bit of dementia, they might be trying to put other things rather than their hearing aid inside their ear, not realizing. So we just want to make sure we've got, you know, a nice clear ear there. Like I said, the battery door, if it's not closed all the way, sometimes that can make a buzzing noise for the patients. Be real, I mean, that would be so irritating if you heard that all the time. Boo, boo, boo. And okay, so external ear. When we're looking at the external ear, we're talking about what we can see kind of out here. You can have external otitis. What is otitis? Yeah, infection or inflammation of the ear. You can have external otitis. You can have all of these issues we're going to go through. So you can have impacted cerumen. What is cerumen? Earwax, right? It's just the medical word for earwax. My son, Preston, he's my ever evolving case study. He makes so much earwax. Like he just always, since he was a kid, would have so much. I mean, they'd bring out, like they'd clean it out and there'd be these balls of wax. Like it's amazing. Like some people are just more prone to making more earwax. Other people don't. My daughter, I sometimes go look in her ears just because I'm curious. I mean, we've got the same parents, there's the same DNA that's there. Her ears are beautifully clean. She never has earwax in her ears. So it's just so interesting to me how you can have like how genetics work and how he's just waxy. Okay. So also with the external ear, you can have masses or trauma that can cause issue, especially if it blocks hearing or causes trauma or causes hearing loss. So if there is infection, we're going to be giving antibiotics for it. Usually it's topical antibiotics if there's infection out here. Sometimes if you have cerumen or earwax impacted, they might do a lavage or an irrigation, try to get that wax to come out. Sometimes some pain medicine or incision and drainage. If you've got a big abscess on your outer ear, they might have to open it up, incision, and then drain out that infected fluid. So what about this question? The nurse is explaining ear care to a patient. Which patient statement would indicate need for further teaching of ear care? So what kind of answer are we looking for? We're looking for the false answers. A lot of good answers here. All right, so for the false statements, let's go over the true statements first. So avoid swimming in contaminated water. If we see water that looks green and yucky, we probably don't want to swim in that anyway, but we, especially for our ears, we don't want to introduce that. Next, earplugs can be used for swimming. That's true, right? If somebody, when we're going to talk about water and things in the ears, sometimes that can cause irritation when the water gets plugged in the ear itself. And so we tell patients to put earplugs when they go swimming. It helps water from getting kind of drained down into the ear and can help prevent infection. Another one, use an ear dryer after swim. That's actually something we do recommend to patients because that kind of standing water that can get kind of stuck out here can cause infection. So we say use a hair dryer, put it on low setting, and you just kind of have air coming through and it will help to dry that excess water. That will help to prevent any infection from forming there in that outer ear. So the false statements, cotton swabs can be inserted into the ear, right? What are Q-tips actually for then? Who knows? Because we know they all truly market them for cleaning your ears, but you're not supposed to, right? So then they show, like, I think the picture on like the Q-tip box is like cleaning a baby or cleaning your keyboard. I'm like, nobody uses it for that. But really, we're not supposed to insert those into our ears, right? The ear must be manually cleaned. Same type of thing, right? We're not supposed to go in and manually do anything in those ears unless you're trained to. And then with the cold, blow your nose with one nair closed. What's false about that statement? The one nair. How should, especially if somebody's had a cold, they're congested, there's a lot of pressure. How should we suggest they blow their nose? Both open, right? Because if they're already a lot of pressure and we're clogging one even more, it's potentially going to be damaging that side of the ear. Okay, so middle ear infections, otitis media. What's another name for? An ear infection. When we call it ear, when we say ear infection, that's otitis media is usually what we're talking about. A lot of times we see this with younger kids. There's actually, it's an anatomy issue, a lot of it. As our eustachian tubes develop as we grow, they change their position, how they drain, and they're more likely to have backup of fluid and things when we're a kid. How do we pull our ears back when we're doing temperature checks? Do you guys remember? Yeah, I think, do I have it on here? I don't think it is, but for kids, because that change in the station tube, usually pull the ear down. And for adults, you pull the ear back and up. That's because as we grow, that tube, that ear canal actually changes in position to our head a little bit. And so that's why kids sometimes will have a lot of ear infections and they'll grow out of it because that position of their station tube changes a little bit. So it's interesting, right? Aren't our bodies so interesting? Okay, so what symptoms do they have? A lot of times we'll see like infection, we'll see fever. A lot of times if they are able to speak, if they're old enough, they'll say it hurts or it feels full, they can't hear. And what are we gonna do? Well, a lot of times we'll do antibiotics or mergonotomy, which surgery, so it might repair. So especially if their membrane has ruptured, right? So much pressure ruptured the membrane in their ear. They might have to have a replacement. Sometimes they'll even put a station tubes in, right? To release some of that pressure that's coming. Here's a little picture from the for your weekly resource page. So sometimes with kids, they can't tell us they're hurting, but they might be pulling at their ears, right? That's a really good signal for kids. They might have a low appetite. They don't feel like eating, but they're real irritable. Sometimes we might see some cervical node enlargements. My son, Preston, I'm telling you guys, he's like every case study. He used to have a lot of ear infections when he was a kid. Fun fact too, he even got like station tubes put in. I mean, we were on first name basis with every provider in his whole clinic because he just was in every few weeks for ear infection. And I think traditional Western medicine is really good for a lot of things. What actually helped him with his ear infections is when we started going to the chiropractor. And so I took my little toddler to a chiropractor and this is how he explained it to me. He said, yes, your station tubes are a little bit different and you grow. If you have a little bit of, what do they call it? Not dislocation, that's not the right word, but if your vertebrae aren't quite aligned how you want them to, if you can do like even small misalignments can cause pressure on one side of the ear or other. And if you can get them more aligned, it allows it to have more drainage. I started taking him to the chiropractor and he never had any ear infections after that. Like it was wild. I was so shocked. I was very skeptical, but they wanted me to take him back to have a second ear tube put in because the first set had fallen out and he kept having all these ear infections. So I said, oh, before I take him for another surgery, I'm just going to try this. Totally disbelieving, and it really worked. So just another thing is that our traditional Western medicine, there's a lot of other types of complementary or other things that we can do to treat that was really effective for him. What I was also going to say was the cervical lymph nodes. So he would have these lymph nodes back in here that would get huge. I mean, he was a kid, he was like a toddler, and they would be these massive lymph nodes because of the infection that it would get his lymph system really going as it was fighting those infections. I remember thinking, oh my gosh, does he have a tumor? What does he have? And it would be from all of these ear infections he'd get these massive lymph node enlargements. One thing you might notice with our little kids is that sucking, if they suck their thumb, they have a pacifier, that's going to probably irritate them. It's going to cause more pain because if you think about sucking, it's going to it increases that pressure in your inner ear. And so with those little kids, that's a sign to look for. If normally pacifier is soothing for them, but they can't stand it, it's hurting, it might be a sign that they've got some ear pressure, ear infection going on. Okay, this so interesting. Different issue altogether. But along your stapes, you get this new bone that starts growing. It's called otosclerosis. Some people just have it where their body decides, hey, I think a bone would look good here. And then they start growing this bone. This bone causes conductive hearing loss, where this bone impacts the sound signals that are able to get through to your ear. So it's usually hereditary, more so in women than men, and it usually does happen bilaterally. So if you have it on one side, it's probably going to be on the other. What does that mean for their hearing? it's going to be affected bilaterally, right? It's not going to be one side versus another, where in otitis media, if you have infection on one side, that's where it's going to be muffled on just that side. With otosclerosis, it's happening on both sides. So you're going to have bilateral hearing loss. There's not a cure, but sometimes they go in and try to have surgery and take out some of that bone. Sometimes they might need hearing aids too to help with that. So interesting. We want to tell them if they have surgery, like for this, the operative ear is upward. The operative ear is upward when lying down. And then we want to have earplugs, right? If somebody's having surgery, especially even with like the station tubes, things like that. We really want to have like, hey, if you're going to go get exposed to some like water, swimming pools, lakes, put in some hearing aids, or not hearing aids, put in some earplugs to protect your ears. We want to teach these guys after surgery, especially trying not to cough, sneeze, blow their nose, vomit, fly, anything that's going to change the pressure in their ear. We want everything to be able to heal up before we kind of are putting extra pressure on that ear. All right, ear trauma. And we're talking specifically about more of that middle ear trauma. So your tympanic membrane perforation. What do you think is the common cause?
Pressure.
I was gonna say Q-tips, those things that we're not supposed to use, but we know they market it for us. We're putting things in there and we don't know. Or people just putting things in their ears. Say people, really usually I mean kids, right? Had kids, they're curious. They're like, hey, what is this for? My little sister, when she was 3, she really wanted to get earrings. And me and my other sister had already gotten our ears pierced. And she really wanted her ears pierced. So she took one of our earrings. Oh, my ear, Amanda, my earring just fell off again.
Didn't you hear talk?
We went out to dinner this weekend and I didn't, this maybe, I don't think it's gross, but I had to use a restroom. I went to flush the toilet and my earring fell out and into the toilet. And I was like, not worth it. And so I just flushed the earring and I was asking, Amanda's husband works with like septic and stuff. And I was like, how bad is that? Is the restaurant gonna like they have to shut down their plumbing or I don't know. Anyway, he said it would be fine. But something about this ear, I'm losing earrings. Okay. So my littlest sister, we got our ears, the big sisters got our ears pierced. We got to wear earrings. And so she got like a little, like a, what do they call the straight little earrings? Not a plug, but a stud. And she took it and she wanted to be like us and she put it in her ear. And my mom freaked out because she was like, I can't get it out. I don't know what's happening. Fortunately, she took her to the doctor and they were able to remove it. It didn't puncture the membrane or anything like that, but very possible, right? Because kids, we don't know. Usually it's kids that are sticking things in their ears, unless it's Q-tips, and then all of us adults are doing it too. Or somebody else said pressure, right? You build up too much pressure. Think about otitis media, that infection gets too much inside the ear and it can actually rupture and cause pressure, all that pressure that the membrane to perforate. Okay, now we're talking about the inner ear. Labyrinthitis. So interesting. We have part of our tissue, that labyrinth in there. It's just inflammation of that inner ear. But anything with our inner ear, there's usually a lot that's associated not only with hearing, but with our balance and stability. So a lot of times these patients, if they have the inflammation of the inner ear, they feel like they can't quite get their feet under them. They're dizzy. They feel like they might fall down. They might have tinnitus. What is tinnitus? Yeah, that ringing in the ears, right? So for these guys, a lot of times we're like, okay, let's treat it. If it's an infection, let's give you antibiotics. If it's inflammation, just from something else, let's maybe give some anti-inflammatories. Let's do some rest. Let's not get up and do a lot that's going to maybe irritate the pressure in the ear. Let's just kind of chill for a little bit. There's also some neoplastic disorders. I'm not going to get into this, but if you have cancer of the inner ear, of course, it's going to affect some of those same things like our cranial nerves. Anyway, moving on. Meniere's disease. Anybody known somebody who's had this? It's a balance disorder because of some fluid disturbance in the inner ear. I've seen a lot of times it can happen randomly, but I've also heard, especially if you're on like a boat or something that moves, so maybe on a cruise, and then you get off, and then like all of a sudden you have this disruption and it kind of can last for a while. And so you usually have some vertigo. You feel like you can't quite hear as well and have ringing in the ears. And it can be very disorienting. I've heard of patients who were like, I couldn't drive for a year because I just couldn't feel like I could see straight or do what I needed to do. It can be constant or episodic where you can have it kind of come and go. With it, so sometimes they'll do just bed rest, sometimes just resting for a bit and then getting up can kind of help. It can also, they might try to do some vagal blockers. So kind of to block that vagus nerve a little bit. Prophylactic though, they might try to say like, hey, let's reduce some of the fluids. Let's do some diuretics. They might also avoid caffeine, tobacco, alcohol, all those things that we know are kind of bad for our body in general. Okay. Oh, I think that's at the end of the thing. Guys, we're done? Holy moly. Okay. All right. I wanted to do, wow, we're so early. Okay. I wanted to do a little bit of the homework review. Bum, bum, bum. Oh, it's in this document. Hold on. Okay. This is from this weekend. I don't know if I can get it where you guys can't see it. Okay, there. Hopefully you didn't see the answer. So maybe you did. This is one of those prioritization questions from your homework. Let me see if we can get this together. So we're taking care of these patients. Let's say that you come on shift, you receive a report on these guys. We're going to talk about which patients might need immediate intervention and put them in the order of priority that we would go assess them and see them. So, and I also want you guys to think about rationales. So patient A, they have severe pain over the right eye. Patient B reports difficulty reading fine print. Patient C reports no improvement in hearing after a stapedectomy. Patient D reports ear pain and crackling noise in the ear. So turn with your groups, compare maybe what answers you had in your homework, and then the rationales. Why would you assess them in that order? Right. Oh, no. Oh, yeah.
Or would be the one. It's the first one. Severe.
Yeah. The last one is.
That's why.
Usually get two. The first and last.
Then, that's why. They just see your proportional. Which that's like, it's very. You don't get improvement in your brain. It's just all the way down.
So what I tried, but.
That's what I thought.
But now I'm questioning that. Most important.
Yeah.
Yeah. I think the least important for me, I put was the.
Fine, great.
Yeah.
Traditionally, this is a. Yeah. So basically, we'll do some more, the third one, which is the words that we'll go through. Stuff
And I
like
literally.
You don't want a lot of typically, the patient floor, obviously. I hope.
But that's all, no, I have.
This is the.
All right, so who's the first patient you guys would go see?
A.
Severe pain, A, and then D, okay, so I see your C, I hear C and D. And then D or C maybe. Is B the last one for everybody? Yeah, okay, that sounds, so just maybe a little question. I think you're right for the first one, and I don't remember the last two or the middle two, so we would see patient A first, who has the pain, right? Because we don't know what's going on with them. We need to assess that. The next one is D, the crackling noise over the ear. It could be an infection, it could be something else. We want to really look at that. C, the stapedectomy. I didn't really talk about this, but it might be a little bit until the hearing returns because of swelling. So yeah, several weeks. And then B would be the last one. They can't see fine print. We want to see what's going on with that. A little more difficulty, but it's not nearly so serious. Let's see. I want to review some of the critical thinking questions from here as well. So the case study we talked about, Miss Liddy, she has a computer data processor and she has recurring eye discomfort about 2 hours after she begins work each day. What do we think might be going on with her? Increased pressure? Maybe the lights? Yeah, so we're going to do a little bit more. So what do we might be happening? Thinking maybe eye strain, but I also think light. If you guys see me wear glasses during the day, usually I'm wearing blue light blocking glasses. Yeah, Shiley.
But on the one, I didn't see more pages besides the 6.
Oh, is this one not on here?
It's the other one. I answered Joffrey again and.
Ah, well, maybe I just had this one as extra. So we'll just talk about it. Thank you guys for clarifying. I forget what things I want to do in class. I thought I already had given this to you to do. So when we're talking about patients about eye strain, like, because a lot of jobs, if you think about over the last 20, 30 years, a lot of things have moved to high use of computers and screens. And it can cause a lot of strain on the eyes, especially that blue light too. I've had students who told me they struggled with studying like on the computer because of the blue light. And so blue light blocking can be very effective at helping with that. Or how do we teach her? Well, we want to teach about positioning of the screen. We don't want it too far where your eyes are having to work too hard. And we don't want it too close where it's not letting our eyes focus like they should, right? And then we also want to make sure that she is how do I get this back over here? She's taking breaks. My grandpa is so funny. Like, I want to say it was in the early 90s before computers were a lot, but I used to read a ton. Like when I was a kid, I always had a book with me. And he would be like, "Hey, you need to take breaks and look out at the trees and things." And I'd be like, "What?" And like, but actually though he was right. I needed to give my eyes a break and I needed to change from looking right here in front of me and then looking far away. So maybe we're all kind of looking kind of like depending on where you're at in the class, but think about it. Next time you're studying, give your eyes a little bit of a break. You're looking really close, or maybe you're just looking at your phone, whatever you're doing, you're looking close. And then take a minute and look and try to see. Well, Mount Rainier's not out today, but look at something far away and kind of focus. It actually helps. It's kind of like stretching for your eyes. Helps them to relax a little bit. Um, Also, I think if you're sitting at a computer desk, getting up and walking around a little bit, maybe not necessarily for the eyes, you are going to focus on other things, but it's going to help you get up, move around, be less sedentary. It's a good overall practice to teach for people. Okay, Mr. Wynn, that's the one you guys did in your homework, right? So he had reported he had difficulty seeing at night and he stopped driving. When he was questioned further, he also stated, "I used to be an avid reader, but I guess I'm getting too old. The words aren't very clear." The nurse checks and finds that he's pretty sensitive to light. He has a little bit of opacity in both lenses. So when you guys are looking, Perla, you guys are going to look on front of the lens, you might be able to see a little bit of cloudiness or opacity. The nurse informs the healthcare provider who plans further testing. So why? What do we think is going on? Yeah, right. It's that film that goes in front of the eye, the cloudiness. Yeah. We think we might be some cataract formation. What diagnostic test do we think we might need? They'll probably do the puffy eye thing, but really, what is the puffy eye thing measuring? Pressure. In which diseases, a group of diseases? Glaucoma is the one that has high pressure. Nice. So we want to do a thorough eye examination. They test the visual acuity, but they'll have like a doc go through and look and specifically look at the cataract itself. The slit lamp, have you guys ever had where you have to sit your chin on it and they have that little slice of light that kind of like looks through your eye, and that will allow the ophthalmologist or eye doctor to really look at that cataract a little more directly. After the healthcare provider made a definitive diagnosis of cataracts, you assist the nurse in developing a teaching plan. What do you include about your teaching plan? So what do we want to teach this guy about cataracts? Post-op stuff, right? Yeah, because if we might say that there's some options for you. They talked about surgery, how to take care of themselves after the surgery. Boo, boo, boo. Medications he might need. And then also important to remember, no swimming even after eye surgery. Sometimes I think we forget about like there's actual incisions in the eye too. And just like for somebody that has an abdominal incision or a knee incision, we tell them not to take baths or swim till it's all healed. We also want to think about that for our eyes as well. And so develop an S-bar to hand off for the next shift. We might say he's a 7-year-old man diagnosed with cataracts. B, background, he had difficulty seeing at night and gave up driving. Used to be an avid reader, but has difficulty with this. Sensitive to light, opaque lenses, and no pain. He has cataracts and needs to be prepped for surgery. And I recommend you reinforce those pre-operative and post-operative teaching to include how to administer eye medication, signs and symptoms of hemorrhaging or infection. I really like that, at least in the example here, it talks about how that continual reinforcing. Anybody been at like some of the surgery units, like Good Sam or some of the other places? Hopefully that if patient is before they're going into surgery, we keep teaching them like how to like some things to expect after, what to do. Especially if you're thinking they're waking up from surgery, what's something that we give them to help prevent atelectasis? And spirometer. When's the best time to teach that? before. If somebody's waking up for surgery, they're all loopy, they're just gonna be trying to blow at it. And it's not gonna work, right? Because we know you have to suck in like you're sucking a straw. And so you want to do those preoperative teaching, teach them while they're awake, while they have the knowledge. And then you want to reinforce it, because if it's the night before surgery, they're going to go be like, hey, just to use the incentive spirometer as example, you know, I'm gonna, hey, I heard we started teaching about this. Hey, could you show me how you use this? I want to make sure you're ready for tomorrow. It's just little things that we continue doing this, and it's going to help the patients to remember. I think that was the end. Okay, so I'm not going to break you up into groups for name that patient, but get into your groups and I will give you some patients to name. Haha. Okay, so give me just a moment to write it down on the board.